Listen, thanks so much. Thanks for the invitation to present today, especially Stephanie and the team. It's great to be here. It's great to be among friends and colleagues and a number of familiar faces as well as some new faces as well. And, I think I was really glad when I saw the topic of the conference for this year and really, I suppose, bringing into centre stage the idea of lived experience in suicide research. And for that reason, I suppose decided to build my talk around some of the more recent work that we have been doing in the National Suicide Research Foundation around formalising the role of lived experience as part of the work that we do. We have quite a long track record of collaboration. I think anyone who works in this space, we naturally want to and need to collaborate with lots of different partners and people working in different areas of this space. But I think about how we include lived experience. This is something that we have started to really formalise over the last year or so. And I thought I would just kind of take you through that kind of process. And I suppose in a more personal and kind of open way, talk about how that has gone. And, it's really made me reflect on some of the things that have been really positive and some of the things that need to change if we are to take this forward in a very real way. So for those of you who may not be familiar with the NSRF, we're a research foundation. We were set up more than 30 years ago. We're based in Cork, in the offices within University College Cork. And the overall purpose of the organisation and our vision is to reduce suicide and self-harm in Ireland and globally through impactful research. We have a long track record of working, for example, with HSE National Office, and most of our research, we have about 13 ongoing active projects that feed directly into Connecting for Life, our national suicide prevention strategy. And the NSRF was established, as I said, in 1994, so that was a year after suicide was decriminalised in Ireland, set up by a psychiatrist, Dr. Michael Kelleher. Some of you may have worked with Dr. Kelleher. I had never met him personally, but from the stories I've heard of the type of person that he was, I think it's no surprise that the organisation is the way it is today because it very much embodies his principles and his drive for social justice, his drive for putting people at the centre of our mental health service. And I think, that was quite progressive when we think about the context in which he worked and the Ireland in which he worked at that time, particularly as a psychiatrist. And I think if you look at some of his research, a lot of it would not be out of place in today's literature, particularly his focus on the social determinants of suicide and self-harm, for example. The organisation looks a little bit different to what it did 30 years ago. Here you can just see a snapshot of some of our team, and we have such a vibrant and diverse and young team of researchers really coming up through the ranks within the organisation today, many of them with their own lived experience as well. And I think that's really important to say and maybe something that we could maybe discuss a little bit later on about how we identify roles within this space as well. And I suppose, one of our kind of core pillars in the way we work is around collaboration. And we're always very mindful of our role as researchers and what we can bring to the space of suicide prevention, and particularly looking at it at a place of how we can enable others to do their job, to deliver services, to develop services that are evidence-based, but also designed with people who need them in mind. And I suppose, we have tried to lots of different activities to allow for that particular support. We do a lot of work in the area of surveillance and collection of data for suicide prevention. And we try and use that data at a local level to really drive change and to inform the quality of services, both in primary and kind of secondary care. We provide quite a lot of advice and expertise around suicide prevention initiatives, and we also try and collaborate with NGOs around initiating and developing research projects, applying for funding, and really providing that support and expertise where possible. One of the other really important pieces of work that we do is our collaborating centre. And we have been a WHO collaborating centre since 2015. And for us, it's a really important role because we're only one of 5 in the area of suicide and self-harm worldwide. And the main purpose of the work that we do as a WHO collaborating centre is around helping other countries develop and implement surveillance systems for suicide and self-harm, but also to inform countries on developing their own suicide prevention strategies. And this work is primarily led by my colleague, Professor Ella Arnsman. We also provide training and education for other governments and other stakeholders, and then also providing advice and co-developing resources with the WHO. It's really important because I think if we talk about suicide prevention, we can obviously focus in on Ireland, where and think about our own local and national policy, but also being mindful in a global context. Nearly 80% of suicides occur in low and middle income countries. And there's a huge amount of stigma in many countries still where suicide hasn't been decriminalised. I think it's important for us to be aware of our potential for advocating for resources globally for suicide prevention, which will naturally over time feed into our own mental health and suicide prevention services. So to date, we've worked with more than 20 countries across all parts of the globe. So it's a really important a layer of our work really to contextualize what we're doing in an international context. So today I'm going to talk primarily about our work in terms of collaboration and using using the expertise and knowledge of people who have lived or living experience of self-harm and suicide in terms of developing the research and engaging with the research that we undertake as a Suicide Research Foundation. And I just wanted to start by showing an example of an output from a recent study that a colleague of mine, Katerina Cavalladu, who's affiliated with the NSRF and also works with the HSE National Office for Suicide Prevention. So Katerina, our colleague, Dr. James O'Mahony from School of Nursing in UCC, undertook a study identifying the needs of members of the Irish traveller community who present to hospital with self-harm. And with a particular focus on women. And so I'll just show this video. I won't say too much more about it.
Hello, I am an Irish traveller woman, and what many people in my community already know is now presented through a national research study. Our community has a rich culture and history, but we can face significant discrimination and health challenges. This new study presents that traveller women often feel isolated and also struggle to seek support within their own community due to perceived stigma and not wanting to burden others. Hospital emergency departments are often the only option for those of us who think of suicide or harming ourselves. However, these busy places are not always ideal for such sensitive situations. Some traveller women don't receive the understanding they need from healthcare workers, which increases their isolation. Support can come from family, partners, traveller organisations and healthcare workers. But if these supports aren't traveller friendly or culturally sensitive enough, isolation can grow. This research found that compared to white Irish women, female travellers were 4 times more likely to visit an Irish emergency department for suicidal crisis. Traveller women aged 40 to 49 are at the highest risk, being 8 times more likely to present in a hospital with suicidal thoughts. while those aged 50 and older have 6 times higher risk of presenting with self-harm. Alarmingly, 1 in 4 female traveller presentations do not want their loved ones involved in suicide prevention. Many link their suicidal thoughts to past traumas, strained relationships, and overwhelming emotional distress. In treatment, some feel they lose control and are constantly monitored, limiting their ability to make their own choices. While some traveller women feel supported and understood by healthcare workers, others experience a lack of empathy, adding to their isolation and frustration. The research also suggested the amazing power of human connection, showing that supportive relationships with partners, healthcare workers, and community organisations can significantly reduce suicidal thoughts. Respectful, culturally sensitive support and awareness, both inside and outside the community, are needed in supporting traveller women in crisis. Let's work together to reduce suicide and self-harm by building a more inclusive and supportive healthcare system for everyone.
So I've seen this video a few times, and I always take away something different every time I watch it, and I just think it's so successful in so many different ways. And you know, one of the things, you know, having the experience of being a researcher and collecting quite complex data, especially from around the prevalence and patterns of people attending hospital, and some of the kind of clinical data that sits behind that research, can be very difficult to translate in a meaningful way where you're really, I suppose, weaving in that personal and lived experience of individuals attending hospital, and what that looks like. And I think it really brings it to life, what it must be like for somebody in crisis like that, presenting to hospital, and what the particular needs are, and brings a really human element to it. So that's, I suppose, I think a really nice example of an output that was fully co-produced by people with lived experience, members of the traveller community, researchers and others who sat down, storyboarded, scripted, agreed on the design, narration, and overall structure of the video. And you know, I think that's what we should be striving for when we start any piece of research, is thinking, what do we want to come from this, and how do we want our research and our messages to be communicated and to be received by others. So in relation to why lived or living experience is important in research, I don't think I need to convince anyone in the room around this. And I suppose when I talk about lived experience, I'm talking about people who have experience of mental health challenges, mental health conditions, people who have experience of self-harm, maybe people who have experience of supporting loved ones or family members, as well as others who may be impacted or bereaved by suicide. So that's quite a wide range of diverse experiences in what I would conceptualize as lived experience as it applies to our work. And I think, as I've mentioned, you know, we all have a common goal. We're all here for one particular reason when we talk about suicide prevention, but we come with our own perspectives, and we come with our own biases as well, perhaps. I tend to relate a little bit to this guy over on the right-hand side, and feel like sometimes when I'm staring into my laptop, I'm very much looking at the back end of that elephant. But when we are researchers and we are working alone, we'll never really, I suppose, generate the type of evidence. We'll never develop the type of research that really represents the complexities and needs of the participants and of the people that we are trying to help. And public involvement in health isn't a new concept, and it has been integrated quite successfully in lots of different areas. I think when we think about mental health and suicide prevention, there are other complexities that we need to think about. So it's an area where there's increased levels of stigma. there's maybe a high degree of mistrust, and that may be in services, but also in research as well. And I think the kind of historical lack of focus on recovery and recovery-orientated services is also a particular challenge that we need to think about. But when it's done well, it's transformative, really. And I think, I've been thinking about how we have incorporated lived experience in our work in the last year. And I think when we put a lived experience central to the work that we do, it allows us to produce research that reflects that diversity and depth of experiences. But it also facilitates in making sure that our research is accessible and is acceptable to a wide range of stakeholders, including members of the public, and ensuring that trust and transparency in the work that we do. Now, I'm used to presenting statistics which are quite stark, and these are two statistics which are stark for other reasons. And for a researcher to say that up to 85% of research funding is thought to be wasted, I mean, that's quite staggering, really. And I think the idea of including lived experience at the start of a research process is so important, because it makes sure that we ask the right questions. It can help with things like making sure that uptake in research is successful, that we have low levels of attrition in particular pieces of research. And it also ensures that we can develop recommendations that are tangible, that are practical, and can be recommendations that we can actually implement. It's disputed, really, how long it can take for research to be implemented into clinical practice, but some of the estimates say up to 17 years. And I think it's only when lived experience is actually integrated across the full research cycle is when we can actually achieve more direct implementation of evidence, and I'll come back to that. So we set up our lived experience panel in 2023 in the National Suicide Research Foundation. And it's been an iterative process. It hasn't been perfect, and we're very much finding our feet with that. And we started very much with consulting with other organizations who had already set up these structures and practices, particularly Dr. Leah Quinlivan from the University of Manchester, and really kind of looked at what was being done in other countries and other settings. I think one of the things that has really helped the panel integrate in quite a short space of time has been that the recruitment of our panel was very much based on the needs of the research that we were doing at the moment. So I talked about lived experience being quite a diverse group of, and representing lots of different experiences. That's really, really important, but we also need to think about how we can incorporate lived experience that's quite specific to particular research questions and particular groups of individuals. And that's why this will be an iterative process, as we'll bring more people on depending on the types of research that we do. We did quite an extensive recruitment of lived experience representatives, and now we have 12 members of our panel actively working with us at the moment across a number of different projects. We've had 2 in-person events around this year alone on the topic of lived experience, and we also have a coordinator and internal steering group who oversee the work of the panel. The panel is very much developed on 2 pillars. One is around support, and the other is on valuing of people's expertise and time. So there's a lot of structures in there, but that needs to be flexible as well to the needs and experience of the people who contribute to our panel. Payment is one thing that really hasn't been addressed properly in the whole area of suicide prevention and mental health. And we do pay our lived experience panel members for their time. It's not perfect. It's not done in a way that I think is to the standard it should be, but that's really important for us, that everyone's time is given the same value and given the same respect. We also have to be aware that it's not as easy for everyone to get to the research table. Other people may have childcare commitments, they may need to take time out of work to be engaged in our lived experience activities. And how can we do that in a meaningful way? We also need to have very important support structures in place, but they do have to be tailored. And that's why time is really important. We put a cap on the amount of hours that people contribute over a particular year. And that may change, but sometimes people will need to step off, or some people will say at certain points, yeah, you know, I can't keep contributing to this project at this particular time. But in 3 months' time, I may be in a place to come back, or I may be able to do this piece of it and not the other piece. And that's really, really important as well, to have those conversations. So I'm not going to talk about the benefits of the panel, really, because I can only talk about it from our perspective now. I'm very fortunate today that one of our lived experience panel members, Mark, is with us at the conference. So I'm sure, Mark, you'll give us your perspective later on in the panel discussion. But there's two pieces that I want to mention. First, I think, is the opportunity for personal growth and recovery for people contributing to research from a lived experience perspective. It can be really helpful to demystify the research process, but also to learn more about the evidence behind suicide and self-harm in particular. And another point I want to mention, I think is really important, is this idea of empowerment. And at a recent event a couple of months ago, one of our lived experience members reflected on feeling empowered, that their role in the project they weren't contributing just because of their lived experience, but actually they were able to contribute broader expertise, knowledge, ideas, and they really felt valued. And I think that comes down to our team and how they have approached and built in lived experience across the projects. It's done in a very open way, it's done in a very flexible way, and people can choose to share about their own experiences. If they want, they can choose not to do so, and they're in control of how they tell that story and who they share that information with. I think that's fundamental, really. So the people who contribute as lived experience representatives, they bring so much more than just that experience, and they have a lot of other skills to contribute as well. So our lived experience representatives work across a lot of different projects. Here's just a kind of a snapshot, and I think it's just useful to think that all of these projects are really different. They have different lifespans, they have different objectives. Some of the work may be reviewing toolkits or public-facing documents that we collaborate with the National Office on. It may be around clinical services, and there's one project which is around clinical decision-making. We have lived experience representatives contributing to our National Self-Harm Registry, for example. And then some maybe more, I suppose, eliciting more kind of qualitative perspectives of people who have been bereaved by suicide, for example. So just to touch on, I suppose, the research cycle and you know, I suppose what would be the ideal way of integrating lived experience in research. And this graphic, I don't know if you can see it very well, but it takes us through the starting point of developing research all the way through to undertaking research, dissemination, and implementation. And I think, you know, within the NSRF, most of the consultation with people with lived experience lies in this quadrant when we're undertaking the research. So it might be in an advisory role. I think we're all very familiar maybe with steering groups where we may have a representative with lived experience. And I think if we want to get serious about integrating lived experience into our research, we need to be thinking of the full cycle. And when we get over to this side of dissemination and implementation, that's where it really tends to fall off. I came across a scoping review as I was preparing for this that found that only 11 studies which were developing interventions for suicide included a lived experience component. So I think the consultation, the informing are all really important activities, But if we want to make a change, we need to be thinking about how do we formally bring in lived experience in terms of intervention development and intervention implementation to make sure that services we're providing are culturally and appropriate and sensitive, but also really clear on the group that they are targeting. So I'm just going to move on to talk a little bit about some examples of of projects where we have incorporated lived experience. And just briefly, we are just finishing up a study where we have undertaken some qualitative research with young people who have been bereaved by suicide. And we've had a lived experience panel running concurrently to this research across all stages. And one thing that came up for us was undertaking interviews with young people, potentially vulnerable in an online setting. And we really kind of wanted to speak with our lived experience representatives about how to do that in a way that didn't add burden to the young people, because they had already made a really difficult decision by contacting us to take part in the research. And also, of course, there's lots of ethical and safety considerations. So there's quite a lot of documentation comes with if you agree to take part in an interview for a research study. So it was how to, present that in a really accessible way and a way that didn't overwhelm the young people. So the lived experience panel members came up with the idea of doing a video that would accompany some of the recruitment material. And some of the things they insisted on, I'm sure Grace wasn't too happy, was having Grace narrate the video and have the interviewer who is going to be meeting the young person actually be visible and make it much easier for them to, I suppose, build that rapport. And then it covered things like what the consent form meant, what purpose was there, and then lots of little tips about what to do during the interview to make yourself feel comfortable. So they really felt that it was important to say to the young person, well, if you need to bring something that's going to make you more comfortable, maybe that's your cat or your puppy, or maybe you want to make yourself something to eat, or maybe you want to bring something that you can draw while you're talking. So I think just a really, really nice example. This idea came from our lived experience representatives. We implemented, and I think it really did help the young people feel a lot more comfortable. Another example, we're developing a module for undergraduate students who will become health and social care professionals. It's a suicide prevention module. So the idea with this project is that every health and social care professional will have consistent training in suicide prevention skills as they enter the workforce. And this is a really nice example of a component of, this is a module for students, and this particular element of wellness was developed by students themselves, very simply by two interns that we had over two consecutive summers. So one of the first things we did when we were developing this module is undertook some focus groups with students themselves about what they needed and what they felt would be the important considerations if they were to take a module like this. This was a focus group that was actually run by a medical student as part of a research internship. And what came up from there was the idea of self-care and support. Students really, I suppose, told us that if you're going to have a module like this, there needs to be a self-care element in there, because we may feel overwhelmed at maybe the content, but also the responsibility that it may place on us as professionals in taking on this role of supporting vulnerable patients. But they also went further and said, well, it can't just be a generic well-being module, and that was kind of one of the solutions. Okay, we'll get them to do this other well-being module in parallel with this piece of work. So they really came back with very practical solutions, and what came out of that was a well-being workbook that was actually developed by students to be integrated as part of this module. We've just finished a pilot of it with UCC and UCD. It's been really, really positive, and students have been coming up during the module saying, can I have some of these workbooks for my friends? And I think anyone who's working in the space of well-being and mental health promotion knows how difficult it is to develop well-being activities that are actually tangible and are actually relevant for that particular audience. So I'm not sure, how am I doing for time? I'm 5 minutes? Okay, perfect. So I'm just going to finish by talking about another piece of work. I see Fiona from Hug in the audience here. And I've said this at the time when we were doing this piece of work, and I still say that it's one of the best examples that I have of doing a fully co-produced piece of research. NASP ran a collaborative grant scheme, which was, I think, really, really successful back in 2020. And myself and Fiona put our heads together to think about what we would do. It was a really great scheme because it actually partnered researchers with people with lived experience and people working in the area of service provision. And Fiona had a great idea of doing a survey of people who had been bereaved or impacted by suicide in Ireland. And there was a lot of things that we talked about. And we wanted to do something that was going to be meaningful, that was going to have impact. And we had seen in the UK that they had done a similar survey. But of course, we didn't just want it to be a survey. We wanted it to be a collection of people's experiences. We wanted the depth and the richness that you might get from interviews. And I was very doubtful of whether we would be able to capture something like that. I think we talked a lot about taking on that kind of role of people trusting us with their experiences and with their stories, and how to do that in a kind of a sensitive way. So this wasn't going to be a 5 or a 10-minute survey. We were asking people to sit down for 20 minutes, for 30 minutes. We were conscious that many people who might take part in this piece of research, it might have been their first time talking about their experience of bereavement. And so that partnership was incredibly important because Fiona and her team really challenged us on our methods, on our approaches, on our language, on how we think about how data is captured and how it's kind of collated. And I think it speaks for itself really in the outputs from that particular work if you have seen the report. And I think, one of the things that worked really well was that we were able to balance a number of different types of data within that particular survey and put people's stories and experiences front and center to that. And I think there really was a sense of openness and people really wanting to contribute to the survey and using their experiences to help others. And I think that comes through very much in the narratives. Just very briefly, some of the things that I think, really were possible because of that partnership that we might not have been able to do alone. First of all, was the response rate and the number of people who took part. I didn't have a number in mind. I was thinking, if we get 500 people, that sounds okay. We'll be able to do something with that research. The only marker we had was that in the UK, they had about 7,500 people complete their survey. Not that we're competitive or anything, but our survey response was relative to the population about 4 times that. So I think, that was absolutely fantastic to get that response rate. The other thing that was a real kind of win for us was the number of men who participated in the survey. It was down at about 18%. It was kind of a stubborn figure for a long time. Fiona and her team undertook a really powerful social media and media campaign, and we managed to get that percentage up to 27%, which is quite successful, I think, for this type of research. And one of the other things I think which was quite interesting was that, most 2/3 of people who participated in the survey had been bereaved in the last 10 years, but that meant 1/3 of people had been bereaved more than 10 years ago. And there's one participant that just stays in my mind. They had been bereaved, they had lost their partner when they were 17 years old, and they were abroad, they had just moved abroad at the time, and that person was in his 70s completing the survey. And I just thought, we've really, we set out what we wanted to achieve by, at least allowing one person to share their story, and they hadn't really, acknowledged that experience at that particular time for them. I suppose one of the other things, I'll just go back to the previous slide and finish on this, really, is that we had said from the start that we wanted to include anyone who felt that they had been impacted by suicide. It was very important to capture the data on family members who have been bereaved by suicide, but also aware that there are other communities and circles of people who have been impacted by suicide that we might not know about. And we've identified, I suppose, a number of priority groups arising from this survey. First of all, friends and classmates, colleagues of people who may have been bereaved by suicide, but also professionals working in the area of health and other professional groups who have been impacted by suicide. So 16% of people who took part in the survey were professionals. They may have been working in frontline services, they might have been funeral directors, psychologists, GPs, and I think that has opened up a narrative and an awareness that often the people that are supporting families bereaved by suicide themselves are carrying an impact and are carrying a trauma over time within that particular role. Okay, so I'm just going to wrap up, I suppose, just with a couple of kind of final reflections. And I don't think I have kind of any one or two kind of clear messages, but I think one of the first things for us is that when we are talking about collaboration and working with people with lived experience as part of our research, communication is really important. It's not going to be perfect. We don't have the perfect structures in place. Every project is going to be different, but approaching it from a place of respect, of trust, of transparency, and setting the expectations from day one, I think is really important, and asking people how they want to contribute instead of defaulting to, let's have a representative on a steering group. Have a conversation about it. See, would that person feel comfortable sitting on that type of a group, or how can we set up the processes that in a better way? And that really comes down to that we can't expect lived experience to slot into our norms and into our research structures, but our research structures are going to have to change if we are going to incorporate lived experience in a meaningful way. That means research is going to take longer. It's going to be more iterative. We're not going to be able to produce a report in 3 months' time. And I'm looking at some of my colleagues in NOS where sometimes we push out the deadlines. But often that might be because we need to do that extra little bit of work to make sure that our outputs are designed in an appropriate way. The other thing that comes from that is funding, and I'm not just talking about cost. It is expensive to do research, and it's expensive to include people with lived experience and collaboration, but the funding structures also need to change. So that collaborative research grant is a really nice example of a facilitated that type of a partnership. It wasn't perfect, but it allowed us to do that piece of work in the way that it was done. But we need to have better funding schemes that actually really allow us as researchers to put those structures in place, and also where we can embed training for people with lived experience as part of that process, and training for our own researchers to be able to do this work, because there's a lot of skills and there's a lot of additional kind of knowledge that's absolutely needed. So it's not always easy, but it's important, and it transforms our research, and I can't really say that enough. And we do have to start somewhere. I'll just end with this particular quote that has been living in my head for about 7 years, because it was a piece of research that we did ourselves. It was a secondary piece of research that myself and some colleagues did, and we published that research. And then I got an email a couple of days later from somebody, and now we had done some consultation, but just not with that person directly. And it just, it always sits with me to get that type of feedback. If only you had picked up the phone, if only you had come and asked us about some context for this, it would have made the world of difference. So that's what I try to think of. We're always going to fail. We're not going to do things perfectly, but hopefully we'll learn from that. And starting with that openness, I think, is half the battle, really. So anyway, thank you so much. And I'd just like to acknowledge some of my colleagues and many of the people who are listed here who contributed to the work I spoke about today.